Welcome back to the deep dive. This is where we take a whole stack of information, could be articles, research, clinical notes, and we really try to boil down to get to those essential insights, the things you really need to know to be, well, truly informed. Today, we're embarking on what I think is a really fascinating medical investigation. We got a detailed patient case in front of us. It starts with something that, well, sounds pretty straightforward at first glance, worsening shortness of breath. But as we start peeling back the layers, looking at this 62-year-old man's medical history, his physical exam, some advanced diagnostics, we're going to uncover, I think, a bit of medical mystery. There are crucial clues here, but they're kind of hidden in plain sight. Our mission today for you listening is really to gain not just, the facts, but a deep mastery of this case. Understanding those subtle distinctions, the critical thinking that gets you to the right diagnosis.
That's exactly right. It's not just about finding the answer, is it? It's about understanding the why. Why is that answer correct? What's the underlying physiology? How do you reason through it step by step? And maybe just as importantly, how do you spot those common pitfalls, those traps that can easily lead you down the wrong path in complex cases like this one? So we'll be dissecting what feels like a real-world medical puzzle, looking at how all these different pieces connect and really highlighting those aha moments, the points where the data clicks and the real picture starts to emerge.
And it's definitely a challenge we've got here. A 62-year-old man progressively worsening shortness of breath. And like you said, this case has some powerful distractors, some things that look plausible but aren't quite right. So our goal, and hopefully your game, is to meticulously use every single detail we have to really nail down the most likely cause of his cardiac and pulmonary findings, and hopefully equip you with a solid framework for tackling any complex information scenario, medical or otherwise. Okay, let's dive right in. Starting with the patient's main complaint, this evolving shortness of breath, dyspnea. He says it's progressively worsening. Now, shortness of breath, that's a broad symptom, obviously, but that progression, that feels key here. What makes this specific progression so significant for us?
Oh, it's absolutely paramount. The progression tells a huge story. Initially, we learned the shortness of breath only happened with exertion, specifically climbing stairs. Now, even that alone, shortness of breath climbing stairs, it already suggests, some degree of underlying cardiopulmonary limitations. Something's not quite right. But the critical development, the real kicker here, is that it has now progressed to occurring even when he's at rest. That escalation, that's a game changer in how we assess this.
Right. And what does that shift from exertional dyspnea to rest dyspnea? What does that immediately signal to you as a clinician? It sounds like a major red flag.
It is, absolutely, a huge red flag. That shift tells us there's been a significant and likely concerning deterioration in his cardiopulmonary function. Think about what that means for his daily life. You go from maybe struggling a bit on the stairs to finding it hard just to sit comfortably, just to breathe easily while resting. That escalation tells us we're not dealing with something minor or stable. This is serious. It's worsening. And it demands a really urgent and thorough investigation. It signals a major compromise in his body's ability to get oxygen where it needs to go, even at baseline activity levels. Often, that progression is the strongest indicator of how severe the underlying disease actually is.
Okay, so with that really serious chief complaint setting the stage, let's turn to his past medical history. What else do we know? He has hypertension, treated with lisinopril, okay, common enough. But then, and this seems really significant, he was diagnosed with gastric cancer 11 months ago, and he was treated with both chemotherapy and surgery for that. These feel like incredibly important clues.
Let's definitely unpack those. The hypertension, like you said, it's very common, a widespread comorbidity. It certainly adds to the overall cardiovascular strain over time, yeah. It's a risk factor for various heart conditions, potentially heart failure down the line. But, just on its own, it doesn't usually explain this kind of acute, rapidly worsening shortness of breath, especially now happening at rest. So we note it. It's part of his background cardiovascular risk profile, but we shouldn't fixate on it as the main reason for his current acute problem. It's a factor, but probably not the primary driver right now.
Got it. So note it, but don't get anchored on it. What about the gastric cancer? Diagnosed 11 months ago, chemo, surgery. That feels like it carries a lot more weight for this current presentation.
You're absolutely right. This history is potentially the most impactful piece we have so far for building our differential diagnosis. We really need to explore all the implications here. A recent cancer diagnosis followed by major surgery plus systemic chemotherapy. That immediately throws open the door to a whole range of possibilities.
Like what specifically? What comes to mind first?
Well, first off, venous thromboembolism, VTE. Blood clots. It's a well-known risk in cancer patients. Malignancy itself can make the blood more likely to clot, We call that cancer-associated thrombosis. And surgery, particularly big abdominal surgery like he likely had for gastric cancer, also dramatically increases the risk of VTE. So clots are definitely high on the list.
Okay, BTE.
Then there's the chemotherapy itself. Some chemo drugs can be cardiotoxic. They can damage the heart muscle. Others can cause lung toxicity, maybe leading to something like drug-induced interstitial lung disease. And of course, there's always the possibility that cancer itself could have spread, causing secondary problems. So this combination of cancer, surgery, chemo, it creates this really fertile ground for potential complications. It really underscores why we need to be so meticulous in evaluating all the evidence. This is exactly the kind of history that, in an exam or a complex case review presents multiple tempting diagnostic paths. Some are right, but many are designed to be distractors. You have to be careful.
Right, lots of potential rabbit holes there. Okay, let's round out his initial profile. We look at common risk factors and his initial vitals. He doesn't smoke, doesn't drink alcohol, no illicit drugs. Good exclusionary info. He's 183 centimeters tall, weighs 68 kilograms. That gives him a BMI, body mass index, of 20 kilograms of fat. So normal BMI. His respiratory rate is 22 breaths per minute, bit fast. But otherwise, his vitals are within normal limits. And here's a really crucial detail. Pulse oximetry on room air shows his oxygen saturation is 96%.
Okay, let's break those down. No smoking, alcohol, or drugs. It's helpful. It immediately lets us sort of deprioritize common causes of chronic lung disease like COPD or maybe liver issues or substance-induced heart problems that help narrow the focus, which is always good.
And the normal BMI, a BMI of 20, that also seems quite useful diagnostically, doesn't it? What does that help us rule out?
It absolutely does. A normal BMI like that pretty much rules out obesity-related conditions. Things like obstructive sleep apnea, OSA, or obesity hypoventilation syndrome. Both of those are known causes or significant contributors to pulmonary hypertension. So right off the bat, we're eliminating some common pathways that could lead to PH. It pushes us to look for other causes. It shows how even seemingly small details like BMI, when you put them in context, can be really powerful discriminators in your clinical reasoning.
Okay, now the vitals. Respiratory rate of 22, that's tachypnea, confirms he's working harder to breathe, he's in some respiratory distress. But then that oxygen saturation, 96% on room air. How do we reconcile those two? Working hard to breathe, but oxygen level isn't terrible?
Yeah, this is where you really have to integrate the data carefully. It's a classic point where you can get misled. The respiratory rate of 22 confirms his body is compensating, right? He's definitely in respiratory distress. Something's driving that increased work of breathing. However, and this is a really critical detail to think about his O2 sat of 96% on room air. While it's not perfect 100%, but it's not indicating severe, profound hypoxemia. This is vital information. It helps us rule out conditions where the primary problem driving his pH is chronic low oxygen or severe acute lack of oxygen.
So, for example, if he had really bad emphysema or widespread lung fibrosis, we'd expect lower SATs, especially if he's breathing fast like that.
Exactly. You'd likely see SATs dipping into the low 90s, maybe even the 80s, particularly with that level of tachypnea. So this 96% is a really strong counterpoint to just assuming severe hypoxia based on the respiratory rate alone.
It's a key diagnostic differentiator then. Don't just jump on the tachypnea and assume low oxygen without looking at the saturation.
Precisely. You have to consider them together. These seemingly small details, like that specific SpO2 number in the context of the respiratory rate, they become incredibly potent in steering you away from diagnoses that might seem plausible but just don't fit all the facts. It prevents us from getting tunnel vision on one symptom. It forces a more nuanced view. It's a common pitfall. Don't let tachypnea automatically equate to profound hypoxia without checking the SATs.
Okay, we've got his story, initial vitals. Now let's move to the physical examination. Often this is where the most telling clues are, quite literally right in front of us. So the exam notes a healed midline laparotomy scar. Confirms the past surgery. But then we see jugular venous distension, JVD, mild hepatomegaly, so an enlarged liver, and bilateral 2 plus pitting edema in his lower extremities, swollen legs. His cardiac exam revealed a loud P2 sound, and a grade 2 out of 6 holosystolic murmur, best heard at the 4th left intercostal space near the sternal border. And then, here's something really distinctive. Brutes, sort of swooshing sounds that get louder when he breathes in, heard diffusely over both lung fields. Wow.
That is a very rich set of findings. Each one adds a crucial piece to the puzzle. The laparotomy scar, yes, that just confirms the history, the gastric cancer surgery. A visual anchor to his past.
But that trio JVD, hepatomegaly, pitting edema, that paints a pretty clear picture, doesn't it? What does that constellation immediately tell us about his heart?
Oh, absolutely. Those are the classic cardinal signs of right-sided heart failure. Systemic venous congestion. It means the right ventricle is really struggling to pump blood forward into the lungs, so blood is backing up into the systemic veins. That's why you see the neck veins distended, JVD, the liver engorged and enlarged, hepatomegaly, and fluid leaking into the tissues causing swelling in the legs, pitting edema. It immediately tells us there's significant cardiac involvement, specifically the right side is failing. It highlights the systemic consequences.
And the loud P2, that's a specific heart sound. What does that signify directly?
The loud P2, that's an accentuated pulmonary component of the second heart sound. Yeah, that's another incredibly specific finding. It's a direct physical exam sign pointing strongly towards pulmonary hypertension. It happens because the higher pressure in the pulmonary artery makes the pulmonary valve slam shut more forcefully, making that sound louder. So it's a clear early clue right there on auscultation that pressures are high in his pulmonary circulation.
Then the murmur. Grade 26 holosystolic, left sternal border, fourth intercostal space. That location and timing are pretty classic for a specific valve problem, isn't it?
Yes, indeed. That description is highly characteristic of tricuspid regurgitation, or TR. What often happens is, when the right ventricle is under chronic strain from high pressures, it starts to dilate, to stretch out. That stretching pulls the tricuspid valve annulus wider, so the valve leaflets can't close properly, they can't coact fully during systole. Blood then leaks backward from the right ventricle into the right atrium when the ventricle contracts. That backward flow is what creates that holosystolic murmur. So we're literally hearing evidence of the right heart being under sustained pressure, leading to these structural and functional changes.
Okay, now for what strikes me as maybe one of the most compelling and highly specific clues in this whole case. Those brutes, louder with inspiration, are heard diffusely over both lungs. That's not something you hear every day, is it? What unique insight does that give us?
You are absolutely spot on. This is a huge clue, a really specific finding, and not common at all. These are essentially flow murmurs you're hearing over obstructed pulmonary blood vessels. The fact that they're diffuse, heard over both lung fields, and get louder with inspiration, that's a powerful indicator of widespread pulmonary hypoperfusion, meaning there's reduced blood flow through large areas of his lungs because the pulmonary arteries themselves are blocked somehow. This finding is pretty unique in its presentation. It points very strongly towards a specific cause for his pulmonary hypertension, likely a mechanical obstruction in the pulmonary arteries themselves. It steers us away from thinking this is primarily a lung tissue problem or a backup from the left heart. Its rarity makes its presence incredibly significant.
Wow. So these physical exam findings aren't just isolated points. They weave together, don't they? They paint this really vivid picture. Right? Heart strain, pulmonary hypertension, and now these very specific clues suggesting why the PH is happening, obstruction. It's a powerful reminder that even with all the technology, a careful, meticulous physical exam is still absolutely crucial.
Couldn't agree more. These signs, when you connect them properly, they start building a really compelling specific story about the patient's pathology. They absolutely guide our next diagnostic steps.
Okay, so the physical exam has given us strong suspicions. Now let's bring in the lab and imaging data to confirm things and, just as importantly, rule out other possibilities. His serum studies, blood tests, and urinalysis show no abnormalities. Okay, chest x-ray shows enlargement of the central pulmonary trunk, a prominent right heart border, and decreased vascular markings. Echocardiography and ultrasound of the heart shows dilation and hypertrophy of the right ventricle, dilation of the right atrium, and that regurgitant flow across the tricuspid valve during systole. And finally, spirometry, the lung function test, shows no abnormalities.
Right. The normal labs in urinalysis are helpful negative findings. They help us rule out things like active systemic inflammation, kidney failure, or major metabolic issues as the main driver here. It keeps our focus squarely on the cardiopulmonary system, avoids chasing down other systemic leads for now.
And the chest x-ray findings seem to really build on the physical exam, right? Enlarged central pulmonary trunk, direct sign of PH. Prominent right heart border suggests the right atrium and/or ventricle are enlarged, matching the right heart failure signs. But those decreased vascular markings, that seems like a standout finding again. What's the big deal about that?
It's a very big deal, yes. Those decreased vascular markings on the chest x-ray are a critical radiological sign. It's often called the Westermark sign, especially when seen with acute pulmonary embolism. What it means is allogemia reduced blood flow to the peripheral parts of the lungs. Why? Because the larger pulmonary arteries feeding those areas are obstructed. Less blood gets through, so the vessels look less prominent, fainter on the X-ray. It's powerful evidence pointing strongly towards a mechanical obstruction within the pulmonary arteries as the cause of his PH. It makes primary lung disease or left heart backup much less likely.
And the echocardiogram then gives us a closer look at the heart structure and function. Dilation and hypertrophy of the RV, dilation of the RA.
Exactly. That confirms the core pulmonale, the right heart, is remodeling under chronic strain, totally consistent with sustained pulmonary hypertension. And seeing the tricuspid regurgitant flow on echo directly confirms the murmur we heard and strongly supports the idea that the RV dilation is stretching that valve open.
And crucially, what does the echo report not mention about the left side of the heart?
That's a critical point of absence. The report details the right-sided problems, but makes no mention of left ventricular dilation or dysfunction. This is a very important piece of exclusionary information that's going to be vital when we start sorting through the potential diagnoses later. The left side appears normal.
And finally, the normal spirometry. What does that lung function test confidently allow us to cross off the list?
That normal spirometry is another key exclusionary finding. It confidently rules out significant intrinsic obstructive lung diseases like COPD or asthma, or restrictive lung diseases like idiopathic pulmonary fibrosis as the primary reason for his shortness of breath and pH. If those were the main issues, we'd definitely expect to see abnormalities in his lung volumes or airflow rates on spirometry.
Okay, so for anyone thinking, well, maybe the chemo damaged his lungs given his history,
Yeah.
the normal spirometry plus the chest x-ray showing decreased markings rather than, say, fibrosis,
Yeah.
that pretty much puts that idea to rest as the primary cause, right?
Exactly. It highlights the difference between a potential complication and one that's actually present and driving the clinical picture. This whole section really shows the power of imaging and functional tests. They confirm our clinical suspicions, yes, but just as importantly, they definitively rule out a whole bunch of alternative diagnoses. It helps us refine our focus, sharpen our investigation, and guide us closer to the actual underlying problem.
Okay, we've gathered a huge amount of clinical and imaging data, and it's all pointing in a pretty specific direction. But now we get to what are arguably the most definitive numbers in this entire case. The results from the right heart catheterization. This is often considered the gold standard diagnostic test here. It reveals a mean pulmonary arterial pressure MPAP of 30 millimol of Hg. Normal is typically 10-20, and absolutely critically, his pulmonary capillary wedge pressure, or PCWP, is 10 millimol Hg. That's perfectly within the normal range of about 5-16 millimol Hg.
Right, that MPAP of 30 millimol Hg, that unequivocally confirms the diagnosis of pulmonary hypertension. By definition, pH at rest is an MPAP greater than 20 millimol Hg, so 30 is clearly elevated. That confirms that he has pH, no question.
But it's the PCWP, that 10 millimol Hg, that's the number that really changes everything, isn't it? It's completely normal. What is the profound significance of that normal PCWP? Why is it so absolutely central to nailing down this diagnosis?
This is, without a doubt, the single most critical diagnostic number in this entire case. Understanding this is key to mastery. A normal PCWP tells us that the pressure in the left atrium, which reflects the filling pressure of the left ventricle, the left ventricular end diastolic pressure, is normal. This immediately and definitively classifies his pulmonary hypertension as precapillary pH. And that distinction, precapillary versus postcapillary pH, is absolutely fundamental. It dictates the entire rest of the diagnostic workup and the potential treatment strategies.
Could you unpack that a bit more? Why is distinguishing between precapillary and postcapillary pH so vital? What does that normal PCWP let us immediately rule out with confidence?
Absolutely. That normal PCWP fundamentally redirects our thinking. It's a powerful exclusion. See, if this patient had postcapillary pH, that means the high pressure in his lungs is caused by a problem on the left side of the heart backing up. For instance, conditions like left ventricular systolic dysfunction, where the left ventricle is weak and can't pump well, maybe a low ejection fraction, or left ventricular diastolic dysfunction, where the left ventricle muscle is stiff and doesn't relax properly to fill, or even significant mitral valve disease on the left side. In all those cases, blood would back up from the failing left side into the pulmonary capillaries, and that backup would cause an elevated PCWP, typically above 15 millimol Hg.
But his is 10 millimol Hg.
Exactly. His normal PCWP definitively tells us the problem is not a backup from the left heart. Instead, the primary issue causing the high pressure must be located within the pulmonary vasculature itself before the capillaries, hence the term precapillary. This immediately rules out that whole huge category of pH caused by left-sided heart disease. It saves us from going down the wrong diagnostic path, like focusing intensely on left heart failure treatments. Understanding the physiological meaning of MPAPE and PCWP isn't just important, it's fundamental. It's how you accurately diagnose and classify pH. This case is a perfect illustration of how precise hemodynamic measurements are absolutely critical. They guide the diagnosis and help avoid major diagnostic errors. This is a vital diagnostic trap to avoid. Always rigorously interpret the PCWP when you're considering left-sided heart disease as a potential cause for PH. It's the ultimate decider between pre- and post-capillary causes.
Okay, so we have those critical numbers. Elevated MPAP confirming pH, but that crucial normal PCWP telling us it's precapillary pH. Now we can really start systematically evaluating the potential causes for the specific type of pH in this patient. Our source material helpfully classifies pH causes into 5 main groups. Group 1 is idiopathic or hereditary. Group 2, left-sided heart disease, which we basically ruled out. Group 3, chronic hypoxic lung disease. Group 4, chronic thromboembolism. And Group 5, unclear multifactorial mechanisms. We have 5 specific options presented for this case. Let's tackle them one by one.
Right. That classification system provides a really good framework. And now, with all the history, the exam findings, the imaging, and especially those key hemodynamic numbers, we can methodically assess each option against our patient-specific profile. This allows us not only to pinpoint the most likely cause, but also, crucially for mastering this, to understand precisely why the other seemingly plausible options are incorrect. That's the core of deep understanding, right? Knowing why things don't fit is just as important as knowing why they do.
Definitely. Let's start with option A, hereditary proliferative vasculopathy. We know this falls under Group 1. It's a cause of pulmonary arterial hypertension, leads to right heart failure. It fits the precapillary profile we found. So in what situation might this be a stronger possibility? And why is it considered less likely for our 62-year-old patient?
Yeah, while hereditary PAH is a real entity and fits the precapillary picture hemodynamically, it becomes much less likely when you consider our specific patient. The key differentiator here is really his age. Hereditary proliferative vasculopathy, often linked to genetic mutations like in the BMPR2 gene, typically affects younger adults. You often see it presenting in childhood, adolescence, or maybe early adulthood, sometimes in women during their reproductive years. Our patient is 62. For him to have a primary genetic cause presenting now, with these rapidly worsening symptoms, is statistically much less probable.
Especially when he has other potential causes from his recent history.
Exactly. If this were, say, a 20-year-old with these findings, maybe a family history of PH and no other obvious risk factors, then a hereditary cause would be much higher on the list. But for a 62-year-old with a significant recent medical history involving cancer and surgery, a late-onset, previously undiagnosed genetic condition becomes a far less likely explanation. Age and demographics are often really important clues in medicine, subtly guiding us away from certain diagnoses, especially when more immediate acquired risk factors are staring us in the face.
Makes sense. Age context is key. Okay, let's jump to option C, serotonin-producing hepatic metastases. This one sounds intriguing because of his cancer history. We know serotonin-producing tumors, like carcinoid tumors, if they metastasize to the liver or in the lung, can cause carcinoid syndrome. And that syndrome can cause shortness of breath, maybe from bronchospasm, and, importantly, right-sided heart valve issues, like the tricuspid insufficiency our patient has. If the source even mentions gastric carcinoid might rarely cause pulmonary stenosis. So there are some connections here. Why is this ultimately considered less likely, even with these overlaps?
Ugh. This is a great example of a diagnosis that looks tempting because some pieces seem to fit. It's a classic diagnostic pitfall relying on partial matches. Yes, the cancer history and the tricuspid regurgitation definitely make you think. And yes, carcinoid heart disease can cause right-sided valve problems. But when you dig into the details, this option really starts to fall apart for this patient. Firstly, while gastric carcinoid tumors exist, they're not the most common site. Carcinoids usually originate in the small intestine or appendix. His primary was gastric cancer. While metastasis is possible, it's less typical. Secondly, while he does have the tricuspid insufficiency, which fits, the source mentions pulmonary stenosis as a rare feature of gastric carcinoid, and importantly, his echo didn't show any pulmonary stenosis.
Okay, so location and specific valve issue don't perfectly align. What's the biggest reason this is unlikely, though?
The absolute biggest reason is the absence of the other characteristic symptoms of carcinoid syndrome. The classic triad is episodic flushing, like sudden redness of the skin, often face and neck diarrhea, and sometimes wheezing or abdominal pain. Our patient's presentation doesn't mention any of those hallmark features. You can't really diagnose a syndrome based on just one or two potentially related findings when the core clinical features are missing. It's crucial always look for the full constellation of symptoms when considering a specific syndrome. Partial matches are often traps designed to mislead you by latching onto one superficial connection.
Right, need the whole picture, not just isolated symptoms. Okay, next differential. Option D, hypoxic pulmonary vasoconstriction. This is a known cause of PH and cor pulmonale, often seen in conditions that cause chronic low oxygen like obstructive sleep apnea, OSA, or chronic lung disease, and COPD, interstitial lung disease, ILD. The source specifically points out that some chemo drugs used for gastric cancer, like taxanes, can cause pulmonary fibrosis, which is a type of ILD. So this feels like a very plausible pathway. Chemo causes lung damage causes low oxygen causes pH. Why should we be cautious here?
This is another one that sounds highly plausible, especially with that chemotherapy link potentially causing lung issues. It's easy to fall into this trap. But again, several key pieces of data from our patient strongly argue against this being the primary driver. First, his profile. Non-smoker, normal BMI, and crucially, normal spirometry. That makes common causes of chronic hypoxia like COPD or OSA much less likely. Second, his oxygenation. That 96% saturation on room air just doesn't support the kind of significant chronic hypoxia that would typically be needed to drive severe pulmonary hypertension and right heart failure all by itself. If hypoxia were the main problem, we'd expect lower sats, especially with him breathing at 22 minutes.
And the imaging.
Right. Critically, his chest x-ray showed decreased vascular markings, not the signs of lung parenchymal disease like fibrosis or interstitial infiltrates that you'd expect with significant chemotherapy-induced ILD. So while chemo can cause ILD, there's simply no objective radiological or functional evidence of it being a major issue in this specific patient. It comes back to distinguishing between a potential side effect and one that's actually present and clinically driving the problem. All the evidence here points away from chronic hypoxia being the main cause of his pH.
Okay, that makes sense. Got to look at the actual evidence in this patient, not just general possibilities. Now let's tackle what you called arguably the biggest, most seductive trap in the whole case. Option E, chemotherapy-induced cardiomyopathy. This one just feels intuitive, right? Cancer patient, got chemo, like anthracyclines, e.g. doxorubicin, often used in gastric cancer, now has shortness of breath and heart problems.
Yeah.
It screams plausible complication.
It absolutely does. This is probably the trickiest distractor for many people, making it a very common diagnostic mistake or MCQ trap. The link between chemo, especially certain types like anthracyclines, and heart muscle damage, cardiomyopathy, is real and well known. Patients do present like this with worsening shortness of breath, often due to left ventricular systolic dysfunction, a weakened heart pump. So the history seems to fit perfectly. But this is where integrating all the data, especially those definitive hemodynamic numbers from the right heart cath, is absolutely paramount.
The PCWP again.
The PCWP again is the key. The patient's normal PCWP of 10 mmHg tells an undeniable story that completely contradicts this diagnosis. Let's walk through why that normal PCWP is so definitive here. Chemotherapy-induced dilated cardiomyopathy primarily damages the left ventricle. It causes left ventricular dysfunction. If the left ventricle is failing, weak, or stiff, it can't handle the blood coming back from the lungs effectively. Blood backs up, pressure builds up in the pulmonary capillaries, and that backup results in an elevated pulmonary capillary wedge pressure. That's the defining feature of post-capillary pH due to left heart disease.
But his PCWP was normal. 10.
Exactly, normal PCWP. That single number definitively rules out significant left ventricular failure, including chemotherapy-induced cardiomyopathy, as the underlying cause of his pulmonary hypertension. The problem isn't originating in the left ventricle.
And the echocardiogram findings back this up too, right? It showed the right side was dilated and struggling, but it didn't mention any problems with the left ventricle size or function.
Precisely. The echo focused on RVRA dilation and TR, but there was a critical absence of reported LV dilation or dysfunction. The source even notes this lack of LV findings is inconsistent with chemo-induced cardiomyopathy being the primary issue. This is such a crucial lesson in diagnostic reasoning. Even the most compelling historical links, like chemo causing heart problems, must be rigorously tested against the objective physiological and imaging data. It just demonstrates the incredible power of one precise hemodynamic measurement, the PCWP, to cut through the noise and definitively rule out a very tempting but incorrect diagnosis. A vital exam mistake to avoid. Always check the PCWP before diagnosing PH due to left heart failure.
Okay, so by careful exclusion and by looking at the evidence that does fit, that leaves us with option B, recurrent pulmonary embolism, leading to chronic thromboembolic pulmonary hypertension, or CTEPH. Let's see how well this fits. The source says CTEPH manifests with cor pulmonale, which he has, results from unresolved PEs, and should be suspected in PH patients with VTE risk factors, like malignancy and surgery, which he has. It also mentions decreased vascular markings on chest X-ray. He has the Westermarck sign, and Brutes over the lung fields. He has the specific flow murmurs. Indicate diffuse pulmonary hypoperfusion, characteristic of CTEPH. It notes VQ scan and pulmonary angiography are used for diagnosis. This seems to tick all the boxes.
It really does. This diagnosis, CTEP, is the one where all the seemingly disparate pieces of this complex puzzle click together perfectly into a coherent and undeniable picture. Let's just systematically walk through why it fits so well, connecting every dot. First, the clinical picture of cor pulmonale right heart failure due to a pulmonary cause. He has the classic signs, JVD, hepatomegaly, edema, and the echo confirms the RVRA, dilation, and TR. That establishes the consequence the right heart is failing due to high lung pressures.
Then the hemodynamics confirm the type of pH, precapillary, right?
Yeah.
Elevated MPP, correct 80-30. But that crucial normal PCWP10, telling us the problem is in the pulmonary circulation itself before the capillaries, not a backup from the left heart.
Spot on. Then, critically, we have those incredibly powerful, highly relevant risk factors for venous thromboembolism. He doesn't just have one. He has two major, recent, overlapping risk factors. One, malignancy, his gastric cancer. Cancer itself, especially adenocarcinomas, creates a hypercoagulable state, making clots much more likely. Cancer-associated thrombosis is a huge risk factor. Two, recent surgery. His laparotomy for the cancer 11 months ago. Major surgery, especially abdominal surgery, involves endothelial injury, immobility post-op, inflammation, all prime conditions for VTE formation.
So the setup for blood clots traveling to his lungs is definitely there.
Absolutely. The stage was set for PEs to occur.
And then we have those incredibly specific diagnostic clues from the examined imaging that really seal the deal for CTEPH.
Exactly. Those decreased vascular markings on the chest X-ray, the Westermarck sign, highly suggestive of underperfused lung areas due to large vessel obstruction from clots. And perhaps most uniquely, those Brutes heard over both lung fields, getting louder with inspiration. Those flow murmurs over obstructed pulmonary arteries are a highly specific physical exam finding pointing directly to diffuse pulmonary hypoperfusion from chronic thromboembolism. You just don't typically hear those in other forms of PH. So when you put it all together, the clinical picture of right heart failure, the precapillary PH hemodynamics, the major VTE risk factors, and these specific X-ray and auscultation findings. Every single piece of evidence converges perfectly on chronic thromboembolic pulmonary hypertension. There are no significant contradictions. It's a masterclass in diagnostic synthesis, where all the clues align to reveal the underlying truth. This is how you achieve mastery of the information.
Okay, now that we've meticulously worked through the differentials and arrived at CTEPH, let's dive a bit deeper into this condition itself, beyond just this specific case. What exactly is chronic thromboembolic pulmonary hypertension? How does it fundamentally develop and differ from other kinds of PH?
Right, so CTEPH is classified as Group 4 pulmonary hypertension. It's a severe and often progressive form. Its fundamental defining characteristic is its cause. It arises from incomplete resolution of acute pulmonary emboli. Normally, after a PE, the body's own clot-dissolving system, the fibrinolytic system, breaks down the clot and the vessel eventually reopens. But in CTEPH, for reasons we don't fully understand in every case, these clots or thrombi don't completely dissolve. Instead, they undergo a process of organization. They become fibrotic, essentially turning into scar tissue that gets incorporated into the walls of the pulmonary arteries. This leads to chronic, fixed obstruction, narrowing, and remodeling of those arteries.
So it's not just a blockage anymore. It's like the pipes themselves are permanently scarred and narrowed.
Exactly. Think of it like debris in a river that doesn't wash away, but instead becomes part of the riverbank, permanently narrowing the channel. This dramatically increases the resistance to blood flow through the lungs, what we call pulmonary vascular resistance, or PVR. Now, the right ventricle, which pumps blood into the lungs, has to work much, much harder to push blood through this high-resistance system. Over time, this sustained pressure overload causes the right ventricle muscle to first thicken. That's hypertrophy trying to compensate. But eventually, if that high pressure isn't relieved, the ventricle starts to dilate, to stretch out, and ultimately it fails. That's cor pulmonale. And that whole sequence, unresolved clots, organized obstruction, increased PVR, leading to RV hypertrophy, dilation, and failure. That's precisely the pathophysiology we saw reflected in our patient's signs, symptoms, and test results.
And we talked about his strong risk factors, malignancy and surgery. Can you elaborate just a bit more on why those two are such significant drivers for VTE, which is the first step towards CTEPH?
Sure. Malignancy, or cancer-associated thrombosis, is a major issue. Cancers, especially adenocarcinomas like his gastric cancer, can actively promote clotting. They can release procoagulant substances like tissue factor directly into the bloodstream. They can activate platelets. They can trigger inflammation that also promotes clotting. It creates this systemic hypercoagulable state where clots form more easily. This risk is highest around the time of diagnosis and treatment, but can persist for a long time.
And the surgery.
Major surgery, particularly abdominal or pelvic surgery like his laparotomy, is another huge trigger. The surgical trauma itself can damage the lining of blood vessels, the endothelium, which is a key starting point for clot formation. Plus, after surgery, patients are often immobile for a period, which leads to venous stasis, blood pooling and flowing slowly in the leg veins, making clots more likely. Add in the systemic inflammatory response to the surgical trauma, and you've got a perfect storm for VTE development. While our patient didn't have other factors mentioned, things like inherited clotting disorders, like factor V Leiden, a personal history of prior clots, prolonged immobility for other reasons, or certain inflammatory diseases also increase VTE risk significantly.
Okay, so given how serious CTEP is and that it starts with unresolved clots, how is it typically diagnosed in practice? What's the usual pathway once a clinician suspects it?
The initial suspicion is key, usually triggered by that clinical picture. Progressive shortness of breath, signs of right heart failure, especially in someone with VTE risk factors, just like our case. Once CTEP is suspected, the crucial screening test is usually a ventilation perfusion scan, the VQ scan. In CTEP, the classic finding is mismatched perfusion defects.
It's matched, meaning?
Meaning areas of the lung are getting air, they're ventilated normally, but they're not getting blood flow. Perfusion is reduced or absent because the arteries supplying them are blocked by those chronic clots. This finding is really helpful because it distinguishes CTEP from most other forms of pulmonary arterial hypertension, group 1 PAH, where you might see matched defects or just diffuse patchy perfusion reflecting disease in the tiny arterioles rather than big vessel blockages.
So the VQ scan points towards CTEP. What's needed to really confirm it and plan treatment?
For definitive diagnosis, and especially for planning potential surgery, the gold standard is pulmonary angiography. This is an invasive procedure where dye is injected into the pulmonary arteries, allowing direct visualization of the chronic clots, the webs, the bands, the stenosis, the actual obstructions. It gives a detailed map of the disease. And right heart catheterization, which our patient had, is also essential. It confirms the pH, measures its severity, like the MPAP and PVR, assesses right heart function, and crucially, measures that PCWP to confirm its precapillary pH. All these hemodynamic details are vital for assessing prognosis and guiding management, especially surgical decisions.
That leads perfectly into treatment. Once CTEP is confirmed, how is it managed? Is it different from how you treat other forms of PH, given that it's caused by these fixed blockages?
Yes, the management is quite distinct, and this is another reason why getting the diagnosis right is so critical. The cornerstone of CTEP management involves two main things: lifelong anticoagulation, and for suitable candidates, a specialized surgery called pulmonary thromboembolic, or PTE. Anticoagulation blood thinners is essential for all CTEP patients. It prevents new clots from forming and stops existing clots from getting bigger, reducing the risk of further acute PEs on top of the chronic disease. This is a baseline, ongoing therapy.
And the surgery, PTE, you mentioned it's specialized. What does it involve, and can it actually cure the condition?
PTE is a truly remarkable operation. It is potentially curative, which is almost unique among forms of severe pulmonary hypertension. It's a complex surgery performed only at highly specialized centers by experienced surgical teams. It involves putting the patient on cardiopulmonary bypass, cooling them down significantly, deep hypothermia, and temporarily stopping blood circulation. This allows the surgeon to carefully go into the pulmonary arteries and meticulously dissect out the chronic, organized, scar-like thromboembolic material from the artery walls. It's like surgically removing the blockages.
Wow.
Yeah. And when successful, it can dramatically lower the pulmonary artery pressures and resistance, allowing the right ventricle to recover. For patients who are good candidates, PTE can lead to massive improvements in symptoms, exercise capacity, quality of life, and long-term survival. This possibility of a surgical cure is what makes accurately diagnosing CTEP so incredibly important. You don't want to miss the chance to offer this to an eligible patient.
What about patients who aren't surgical candidates?
That's a great question. Not everyone is suitable for PTE, maybe because their clots are too far out in the small vessels where the surgeon can't reach them, or they have too many other severe health problems. For those patients, or for those who still have significant pH after surgery, residual pH, there are now specific medications approved for CTEP, targeted pH therapies that can help manage symptoms, improve exercisability, and potentially slow disease progression. There's also a procedure called balloon pulmonary angioplasty being used in some centers for non-operable disease. But PTE remains the gold standard curative approach when feasible.
That's incredibly important. Understanding the difference between CTEPs and other types of precapillary pH isn't just academic. It directly impacts whether a potentially curative surgery is on the table. It really raises the stakes for getting the diagnosis absolutely correct. This whole deep dive really drives home how crucial integrated critical thinking is. It's not just about knowing isolated facts, is it? It's about weaving together everything: the patient story, the physical exam clues, the labs, the imaging, the hemodynamics, using each piece of data to support or refute potential diagnoses, and building the strongest case based on where all the evidence converges. Let's quickly recap those common diagnostic pitfalls, those MCQ traps, and exactly why they were wrong here. Really crystallize the learning points for mastery.
Absolutely, because truly mastering this means knowing the why not just as well as the why. Pitfall number one, probably the biggest one. Chemotherapy-induced cardiomyopathy, option E. Why was it so tempting? Because cancer plus chemo plus heart problems makes intuitive sense. Why was it wrong? The normal PCWP, 10 mmHg, that's the killer piece of data. Left heart failure always causes an elevated PCWP due to backup. Normal PCWP definitively rules it out. Remember that fundamental link.
Okay, pitfall 2. Hypoxic pulmonary vasoconstriction, option D. Tempting because chemo can cause lung disease, ILD, potentially leading to hypoxia than pH.
Right. Why was it wrong? Multiple reasons. Normal oxygen saturation, 96%, normal spirometry, and no signs of ILD on chest x-ray. Instead, decreased markings. There was simply no objective evidence of significant chronic hypoxia or relevant lung disease in this patient. Don't assume a potential complication is present without proof.
Pitfall 3. Serotonin-producing hepatic metastases, option C. Looked plausible because of the cancer history and the right-sided heart valve issue.
Yeah, but why was it wrong? Primarily the absence of other core carcinoid syndrome symptoms like flushing and diarrhea. You need the full clinical picture for a syndrome. Also, the primary cancer site, stomach, is less typical for carcinoid origin, and the echo didn't show the specific valve issues sometimes linked. Pulmonary stenosis. Partial fits are often misleading.
And finally, pitfall 4. Hereditary proliferative vasculopathy, option A valid cause of precapillary pH.
True, but why wrong here? The patient's age, 62, hereditary forms typically present much younger. In the context of his age and compelling acquired risk factors, cancer, surgery, a late-onset genetic cause becomes highly improbable. Demographics matter.
That's a great summary of the traps. So for you listening, aiming for mastery, what are the absolute key diagnostic signposts, the non-negotiable takeaways from this case? What were the truly pivotal pieces of information?
Okay, let's boil it down. From the physical exam, remember that loud P2 signaling pH? Remember the triad of JVD, hepatomegaly, edema signaling right heart failure? And don't forget those highly specific brutes over the lung fields pointing strongly towards CTEP. From imaging, look for the enlarged pulmonary trunk and right heart border confirming PHR-HF, but critically, look for those decreased vascular markings, Westermarck sign, super specific for large vessel obstruction like PECTEF, from physiology hemodynamics. The elevated MPAP confirms pH, but the absolute linchpin is the normal PCWP. That confirms precapillary pH and definitively rules out left heart failure as the cause. Those are the key pieces. When you put them all together in this case, they formed an undeniable picture pointing straight to CTEF, allowing you to navigate away from those tempting distractors. That's the path to mastering this information.
And this whole process, this deep dive approach, it really empowers you, doesn't it? To tackle any situation where you're flooded with information, medical or otherwise. To learn how to structure your thinking, weigh the evidence, build a robust argument, and navigate complexity with confidence. So we've really journeyed through a complex medical narrative today, haven't we? Started with that worrying symptom, worsening breathlessness, and then we systematically uncover this trail of intricate clues. From the subtle progression of his symptoms, to the loud P2 and those unique brutes on exam, to the decreased vascular markings on his x-ray, and absolutely critically, that definitive normal PCWP. Every piece eventually converged, leading us squarely to the diagnosis of chronic thromboembolic pulmonary hypertension, CTEP-H. We saw how his history, the cancer and surgery, laid the groundwork with compelling risk factors, and how meticulous evaluation and
rigorously ruling out those tempting alternatives finally revealed the underlying truth.
It's such a powerful reminder, this case. Even when a patient comes in with a history that seems to point strongly in one direction, like cancer and chemo effects, the body often provides its own specific, undeniable signals through physical signs and objective tests, if we look closely enough. It really challenges us to look beyond the most obvious, maybe superficial, associations, to dig deeper into the unique story that each specific set of symptoms and test results is actually telling us. Just imagine for a second, if this patient's PCWP had been elevated, say 25 millimole HD instead of 10, how dramatically would our whole diagnostic journey have shifted? We'd be focused entirely on his left ventricle, wouldn't we? What completely different condition would have been the center of this deep dive? Maybe chemotherapy-induced cardiomyopathy would have been the right answer then. That single number, the PCWP, held the power to fundamentally change everything our understanding, the diagnosis, the treatment. It highlights the immense power held within precise physiological measurements.
That is a truly profound thought. It really underscores the weight of getting those precise measurements and interpreting them correctly. So keep asking why. Keep connecting all the dots. Don't just stop at the surface level and keep diving deeper. You've been listening to The Deep Dive. We'll catch you next time.